Hello and welcome to Easy Learning with Dr. Salman. Then next is the pathogenesis, mode of infection, inoculative method. By the bite of the infective tsetse fly, Glossina, both male and female suck blood and can transmit the infection. They bite by daylight, usually in the early morning and evening. The trypanosomiasis, that is the metacyclic stage, are introduced by the fly with the saliva into the subcutaneous pool of blood on which it feeds. Some of the parasites may enter the bloodstream directly, but the majority becomes entangled in the tissue spaces. The initial growth of the trypanosomiasis is in the tissue spaces, which form a more favorable nidus, or probably here the organisms escape the action of antibodies which might be developed. It is to be noted that while the trypanosomiasis are multiplying in the subcutaneous tissue spaces and causing damage, the organisms are either absent or present in small numbers only in the peripheral blood. It has been suggested, although unlikely, that the connective tissue damage caused by the trypanosomiasis may be due to an exaggerated immune response, that is, autoimmune reaction or massive release of kinins, rather than to any direct effect, that is, mechanical damage due to motility of this relatively non-toxic organism. Then the host response. The presence of the trypanosomiasis in the subcutaneous connective tissue excites host's response in two ways. First, by producing a large amount of non-specific immunoglobulins, which are however not capable of sensitizing the antigen. Antibodies are produced in response to the secretion of an exoantigen of the trypanosomiasis. Second is by heavily infiltrating the site of infection with macrophages, the cells competent to deal with the invaders. The neutrophils take peculiarly little interest in the defense and are therefore not much in evidence. Thus, it will be seen that there is no lack of mobilization of the host's defensive mechanism, but it is the cellular defense which plays the dominant role. The macrophages could be seen to remove the living trypanosomiasis in the tissue spaces. The release of kinins may help to attract macrophages. It also increases the capillary permeability of tissues and may explain the edematous swollen subcutaneous tissue at the site of infection. Next, pathogenic lesions. These are seen in the following three areas: the connective tissues, lymph nodes, and the central nervous system. The connective tissues. There is severe damage of the perivascular connective tissues. The bundle of collagen fibers are disrupted and the fibroblasts are destroyed. In the lymph nodes in early stages show congestion, hemorrhages, and marked proliferation of macrophage cells. In the later stages, they undergo degenerative changes with extensive fibrosis. In the central nervous system, the capillary blood vessels of the central nervous system are not surrounded by any connective tissue matrix, but the nerve cells are embraced by the overlapping fibrous processes of the astrocytes. An increase of glial cells occur throughout the central nervous system, and the cerebral perivascular spaces are cuffed with mononuclear cells. This is called as perivascular cuffing. Cerebral softening may result from thrombosis of these cuffed vessels. The choroid plexus is severely congested and infiltrated with monocytes, often containing a large number of parasites. There is heavy cellular infiltration in the leptomeninges, but slight infiltration in the brain substance. Then the characteristics between West African trypanosomiasis and East African trypanosomiasis. The organism in West African trypanosomiasis is Trypanosoma brucei gambiens, whereas in East African trypanosomiasis it is Trypanosoma brucei rhodesiensis. Distribution in West African trypanosomiasis, it is in the West and Central Africa, whereas in the East African trypanosomiasis, it is in the East and Central Africa. The vector in case of West African trypanosomiasis is the tsetse fly, which is the Glossina palpalis group, and in case of East African trypanosomiasis, it is the Glossina morsitans group. The reservoir in case of West African trypanosomiasis, mainly humans, and in East African trypanosomiasis, it is wild and domestic animals. Then virulence. Virulence is less in West African trypanosomiasis, whereas more in East African trypanosomiasis. Then the course of disease. West African trypanosomiasis is chronic, which takes months to years, and in East African trypanosomiasis it is acute, which takes less than 9 months. Parasitemia in case of West African trypanosomiasis is low, whereas in case of East African trypanosomiasis it is high and appears early. Lymphadenopathy in West African trypanosomiasis occurs early early and is prominent, whereas in East African trypanosomiasis it is less common. Mortality in case of West African trypanosomiasis is low, whereas in case of East African trypanosomiasis it is high. Then next is the clinical features. Trypanosoma brucei gambiens causes African trypanosomiasis, which is also called as West African sleeping sickness. The illness is chronic and can persist for many years. Trypanosoma brucei rhodesiensis causes East African sleeping sickness, also called as East African trypanosomiasis, which is more acute than the Gambian form and appears after an incubation period of 4 weeks. It may end fatally within an year of onset before the involvement of the central nervous system develops. About the West African sleeping sickness, there is an initial period of parasitemia, following which parasite is localized predominantly in the lymph nodes. A painless chancre, which is called as trypanosomal chancre, appears on the skin at the site of bite by a tsetse fly, followed by intermittent fever, chills, rash, anemia, weight loss and headache. African trypanosomiasis is divided into 2 stages. Systemic trypanosomiasis without central nervous system involvement is referred to as stage 1 disease, whereas when there is invasion of the central nervous system, it is referred to as stage 2 disease. First, stage 1 disease. In this stage, there is hepatosplenomegaly and a lymphadenopathy, particularly in the posterior cervical region, referred to as Winterbottom's sign. Myocarditis develops frequently in patients with stage 1 disease and is especially common in Trypanosoma brucei rhodesiensis infections. Hematological manifestations seen in stage 1 include anemia, moderate leukocytosis and thrombocytopenia. High levels of immunoglobulins, mainly immunoglobulin M, that is IgM, are a constant feature. Then stage 2 disease involves invasion of central nervous system, which occurs after several months. The sleeping sickness starts. This is marked by increasing headache, mental dullness, apathy and daytime sleepiness. The patient falls into profound coma followed by death from asthenia. Then the histopathology, it shows chronic meningoencephalitis. The meninges are heavily infiltrated with lymphocytes, plasma cells and morula cells, which are atypical plasma cells containing mulberry-shaped masses of IgA, that is immunoglobulin A. Brain vessels show perivascular cuffing. This is followed by infiltration of the brain and spinal cord, neuronal degeneration and microglial proliferation. Then the abnormalities in the cerebrospinal fluid include raised intracranial pressure, pleocytosis, that is increase in cell count, particularly WBCs, and raised total protein concentrations. Next, clinical staging of human African trypanosomiasis (HAT). Stage 1 is characterized by hematogenous and lymphatic dissemination of the disease. Stage 2 is characterized by central nervous system involvement. These were the clinical features of Trypanosoma brucei gambiens. Next, about the East African trypanosomiasis. It is more acute than the Gambian form. Pathological features are similar in both diseases with some variations. Edema, myocarditis and weakness are more prominent in East African sickness. Headache, diffuse muscle and joint pain are present in majority of the patients. Lymphadenitis is less prominent. Febrile paroxysms are more frequent and severe. There is a large quantity of parasite in the peripheral blood. Central nervous system involvement occurs early. Mania and delusions may occur, but the marked somnolence which occurs in Trypanosoma brucei gambiens infection is lacking. This is all about the clinical features. Then the laboratory diagnosis. It is done in the following ways: microscopy, culture, imaging, serodiagnosis, molecular diagnosis and others. First, the microscopy. Definitive diagnosis of sleeping sickness is established by the demonstration of trypanosomes in peripheral blood, bone marrow, lymph node, cerebrospinal fluid and chancre fluid. Wet mount preparation of lymph node aspirates and chancre fluid are used as a rapid method for demonstration of trypanosomes. These specimens are also examined for parasites after fixing and staining with Jamesa stain. Examination of Jamesa stained thick peripheral blood smears reveals the presence of the trypomastigotes. If parasitemia is low, then examination of concentrated blood smear is a highly sensitive method. Different concentration techniques employed are Buffy coat examination, differential centrifugation, membrane filtration, and ion exchange column chromatography. Examination of wet mount and stained smear of the CSF may also show trypanosomes. Then culture. The organisms are difficult to grow, hence culture is not routinely used for primary isolation of the parasite. However, it can be cultivated in Weinmann's or Tobey's medium. Then imaging. Computed tomography, a CT scan of the brain shows cerebral edema, and magnetic resonance imaging MRI shows white matter enhancement in patients with late stage central nervous system involvement. Next, serodiagnosis. It is of two types: antigen detection and antibody detection. Antigen detection. Antigens from serum and CSF can be detected by ELISA. Antibody detection. Almost all patients with African trypanosomiasis have very high levels of total serum IgM antibodies and later CSF IgM antibodies. Various serological methods have been developed to detect these antibodies and are as follows: indirect hemagglutination IHA, indirect immunofluorescence IIF, enzyme-linked immunosorbent assay ELISA, card agglutination trypanosomiasis test CATT, complement fixation test CFT. Specific antibodies are detected by these tests in serum within 2 to 3 weeks of infection. Specific antibodies in CSF are demonstrated by IIF and ELISA. These serological tests are useful for field use and mass screening. Next, molecular diagnosis. Polymerase chain reaction PCR assays for detecting African trypanosomes in humans have been developed, but none is commercially available. Next, others. These are blood examination, animal inoculation, and isoenzyme study. Blood examination, non-specific findings: anemia and monocytosis, raised erythrocyte sedimentation rate ESR due to rise in gamma globulin levels, reversal of albumin globulin ratio, increased CSF pressure, and raised cell count and proteins in CSF. Then animal inoculation, and then isoenzyme study. More recently, their differentiation is based on isoenzymes, deoxyribonucleic acid DNA and ribonucleic acid RNA characteristics. This is all about laboratory diagnosis. Lastly, prophylaxis. Control is based on early diagnosis and treatment of cases to reduce the reservoir of infection. Control of CC fly population, which is the most important preventive measure, by wide spraying of insecticides, traps and baits impregnated with insecticides. This is all about the parasite Trypanosoma brucei. If you wish to see more of such videos, do comment below. And don't forget to like, share and subscribe to my channel. Also, press the bell icon for early notification of my new videos.